Okay, I've started the recording for the meeting. So I'd like to welcome everyone to the second of 3 demos that we're doing this week. We had an excellent demo yesterday from the team at One Hits. And so today's demo focuses on the emergency room and emergency services. And we're really looking forward to seeing some of the things that Expanse can do for that. So One Hit, for those who are unfamiliar, is the group that it's the One Health Information Technology Service. They work out of, have been working with the Northeast group. So they've implemented Expanse in 23 hospitals across the Northeast, and they are partners. We're now partners with them to bring that system to the Northwest. So the advantage is, today you'll be seeing the system as it exists today in the Northeast in their test system. And we have the chance, as we start our program, to take this system and look through it, see what will work for us, make some suggestions or things that we need for our programs here, and work with One Hits to build those as we need them. So I will pass it over to Maria Watling, and she'll tell us a little bit about the demo today. Thanks, Maria.
Thanks, Sandra. Good afternoon, everyone, and welcome to our second demo. I'm Maria Watling. I'm the Clinical Applications Build Manager for One Hits, and we're really excited to have you with us today. Erin Zapshala and Sherry Rogers will demonstrate how Meditech Expanse is used during an emergency visit. But before we get started, I just wanted to let everyone know that the session's being recorded, and to keep us running smoothly, we're asking that you type your questions in the chat as we go, and our team will answer those questions in the chat as well. And at the end of the session as well, we will have a Q&A session. With that, I'll hand it over to Erin and Sherry.
Perfect. So I'm just going to share my screen. So as Maria said, Sherry and I are going to walk you through typical ED visit for that non-admitted patient. And can you guys see my Meditech screen? Yes, I now get my pop-up. Okay, so what you're seeing right here, this is the home screen of the emergency department module. You'll notice that some of the screens throughout the modules do look very similar. I can tell that I'm in the emergency department module because I have a button for reception at the top, and this allows us to pre-register patients directly into the emergency department. And I have a triage button, which obviously is going to allow us to triage some patients. Other things I want to point out before I get into the actual workflows is down here, you'll notice I have a series of tabs that I can click on. We call these trackers in the emergency department, and essentially your trackers are electronic whiteboards that are going to allow you to view your department either by location, so like your waiting room or your fast track area, or by certain events in the department. So if I just wanted to see how many admitted patients I have waiting for bed, I have a tracker for that. If I want to see how many patients are waiting to see an emerge physician, I have a tracker for that. So staff can toggle back and forth and personalize and reorganize those for their shifts. The actual trackers themselves do look similar tracker to tracker. I have a location column, and this is going to show me the area in my department and the bed that this patient is in. I've got basic demographics, so I've got patient's name and age. I've got a registration status. Chief complaint, CTAS level, and length of stay is identified on a tracker. I have a couple of indicators on my tracker that help me as the nurse be alerted to new work I might have to do. So I can see I've got a bunch of orders on patients. This patient has some blood transfusing, so I'm alerted that there's some actions I need to take. And this column is going to show me that ED care team. If I hit this little expand arrow on one of these trackers, my tracker expands and reveals what we call a detail box. A detail box is just a way that we can pull pertinent patient information to the forefront that may live in different aspects of the chart. So this first column typically is going to show account level information, so health card number, maybe patient's date of birth, those triage, isolation precautions that were applied, allergies. The second column is going to show me things that I might have to do as a nurse. So any outstanding assessments or medications I might have to administer. And that last column is really going to show me information when my patient's admitted. So admission service, diagnosis, things like diet, activity. Last thing I'm going to show is this item right here. We call this an ED status event. It's unique to the emergency department module. If I click into this field, I get a list of status events that are active for my facility. They go in order of patient arrival all the way down to some post-discharge activities. I can manually click any one of these fields to apply it. It's going to update it on all my trackers. Some of these status events also automatically apply when an action is taken. So initially my patient had an admitted patient status event. This occurred automatically when this patient's ED account was rolled into an inpatient account. If I scroll down, this patient has an MD assess. This occurred automatically when that physician signed up for a patient. So status events are really helpful in communicating with the ED department where this patient is in their journey through the emergency department. It's also time-stamped in the background, so your ED staff can definitely use these to help supplement some of their documentation. Okay, so I'm going to walk you through what reception and triage will look like. So we're going to pretend that I'm that triage nurse. I'm sitting at my triage window. Patient arrives to the department. How I enter them into the system is I'm going to go ahead and hit this reception button at the top. And the patient hands me their health card number. So I am going to type in the health card. I might have a health card swiper or scanner, but I'm going to type in that health card number. I get a pop-up asking me if I want to search the master patient index. So search the system and try to find this patient. MPI search is done once in an ED visit. I can do it right now at reception. I can defer it until triage or wait until registration, but at some point it has to be done. I'm going to go ahead and just search this right now for the sake of this demo. Because I've entered in that patient's health card number, that's the criteria it's searching, and it comes back and gives me a hit. Had I just entered, say, the patient's last name of ZAP, I might have gotten 10 or 15 search results. So now I really have to filter through and ensure I'm picking the right patient. So I've got the health card number. At this point, I'm going to ask the patient, what's your name? Can you confirm your birth date? I want to really make sure that I'm selecting the right patient. I go ahead and make my selection. This is my reception screen. So some of those patient demographics pull in. Anything with an asterisk is a required field. So I did ask the patient to verify this birth date. I can check that off. I need to enter in a stated complaint. So this patient tells me they've got right-sided flank pain times 24 hours. You guys get to watch me type in real time. North Bay, that's the site that I'm demonstrating with. They require a preliminary chief complaint and a preliminary triage level for their workflow. So I'm going to go ahead and do that. This chief complaint field, this points to the complaint dictionary that has all 169 CETAS complaints in it. I definitely can scroll through looking for flank pain, or when I get more comfortable with this dictionary, I can start to type in a couple key letters and hit enter and pull up that chief complaint. I'm going to enter a preliminary CTAS score, knowing I have not yet triaged this patient. And again, some of these required fields can be customized by site. Automatically, my arrived by arrival mode defaults to no ambulance. If this patient came by police or air or ground ambulance, I can update that field here. And my area is automatically going to default into my waiting room. If this patient was coming in and going directly to the trauma room, I could update that right on this field. So I'm going to go ahead and hit save. I have the ability to print an armband at this time. I'm going to just hit cancel right now. I don't have a scanner. I now get a pop-up just alerting me that there may be a medical directive that's appropriate for this patient based on that chief complaint. Some sites are completing their triage all from that first screen, so they would go ahead and do that. I'm just going to break it out. So right now I'm going to say no thanks, maybe later. So if I head to my to be triaged tracker, I now see this patient. So I would highlight their name and head up to this triage routine at the top. So at the top of my triage routine, I have a list of suggested triage assessments. Sites can set their own, so we do have some variation across one member sites. I can triage directly in Meditech by using this form. By September of this year, all one-member hospitals will be using ECTAS to complete their triage assessments. My understanding of the Northwest is in September as well. Your sites will be implementing ECTAS Basic. What I'm going to show you for this demo is what it looks like when ECTAS and Meditech are integrated, which is the bulk of our one-member hospitals. So Meditech and ECTAS will talk to each other. So in real life, what would happen is on a separate tab at the top, I would log into ECTAS at the start of my shift, and I would just toggle back and forth between the tabs. But for my screen at home, I have to just log into ECTAS on a different screen. Can you guys see my ECTAS screen?
No.
No. Okay, so let me just share it again. Okay, Krista, can you see ECTAS now?
No. Oh, now we're here. Yep.
Okay.
We are.
So this is what ECTAS will look like.
Can you make it a little bit bigger? Just a little bit small.
Bigger, yeah. Thank you.
Yeah.
That all right? Good.
Yes.
So Meditech has sent that information to ECTAS. I've got my patient here. That patient has landed on the pre-triage patient list. So I'm going to go ahead and select this patient and hit continue to triage. You'll notice that my chief complaint and my modifiers are blank. I need to fill out a CETUS complaint again. So I'm going to put flank pain back in. Once I do that, my base score of 5 is applied. I have some modifiers. I would go in and type my triage assessment. And I would go ahead and enter in some vital signs. I'm going to just put in some very basic, normal vital signs. Just bear with me. Oh, I didn't put in a systolic, that's fine. So my score is still a 5. I want to assess my patient's pain. So this patient tells me they've got 4 on 10 pain. They look pretty uncomfortable. Once I enter in my pain, my score is going to change. ECTAS is going to tell me that this patient, based on what I've entered into the system, should be a CTAS 3. I can disagree with this and override and bump my patient up 1 score, but based on what I'm seeing on my assessment, I agree with this. So I'm going to go ahead and hit I'm done triage. My patient is now moved from this pre-triaged patient list to triaged. Meditech will save this and then send it back into ECTAS. At some point in Meditech, I'm going to register this patient, and Meditech will send one last message into ECTAS, sending a TOA and theoretically closing this account. So now I'm going to return back to my Meditech screen. Sorry, guys, I'm jumping back and forth. Oh, there we go. Okay. So
Yeah, we can see.
I'm going to do my infection control and my height and weight. So I can stack check marks, and I can do more than one assessment on one screen instead of doing it one at a time. So these are your basic infection control questions. So has your patient traveled out of the country, been around anyone who's sick, new or worsening cough, fever, you know, those typical questions. Does look a little bit busy on the screen, but I do promise like one shift at triage and your nurses would be able to rhyme this off in their sleep. I am going to add in height and weight. So particularly North Bay, we do stated or estimated weights on every adult patient. We do record an actual weight on pediatric patients. So we're going to say that this patient told me that they're 6 feet tall. I can type in feet and automatically it's going to convert this to meters. And I'm going to say this is stated. And let's say this patient tells me they're 200 pounds. Again, I can type in pounds and it's going to convert it to kilos. Once I have both metrics in, it's going to auto apply a BMI. Nice thing about having a height and weight in, particularly for pediatric patients, is when a physician orders a weight-based drug, it's going to calculate your dose for you in the MAR. So I'm going to go ahead and hit save and exit at the top. Other thing I can do at triage is maybe I'll verify some allergies. So I'm going to click into the allergy field. I see this patient has allergies for codeine and shellfish on file. I'm going to confirm with them that these are still accurate and that the reactions are accurate. Go ahead by clicking confirm. I could definitely remove one if it was wrong or enter in new allergies. Let's say it's a really great day at triage and I have lots of beds in my department. I can move this patient directly into a room. So if I hit ED location right now, the default was the main waiting room. I can click into this field. These are all my areas in my department. I'm going to put this patient in my exams area. And I'm going to put this patient in exam room 7. I can see that that bed's clean. And the last thing that I want to do at triage is remember that pop-up alerting me that there's medical directives. I can initiate those. So I'm going to go ahead and hit orders on this top bar to launch into the orders routine. I need to pick a provider and I need to pick my source. So I know that Dr. Brill's working my exams room. My assumption is it's going to be her that sees the patient. So I'm going to enter this medical directive under Dr. Brill. And my source is going to be medical directive. Because I have an associated or recommended medical directive based on chief complaint, it's going to show nicely here. I definitely can search the catalog of ED medical directives by typing into the search field, but this is actually the one I want. If I hit this expand arrow, the top, I've got a patient description of who this is appropriate for. You'll see if I scroll down that I've got some orders that are pre-selected, so I can insert a saline lock. I have a medication that I may order. So I've got Toradol 10 milligrams IVIM. It is not selected because I've got a list of indications and contraindications, and the system's just not quite smart enough to decide whether or not this patient has met those criteria. But having done my triage assessment, I know that this is an appropriate medication for the patient, so I'm going to go ahead and order that. I've got some blood work. If I keep scrolling down, you'll see that I've got a pre-selected urinalysis, which is appropriate. This patient has flank pain, history of renal colic, and some hematuria. Patient's 45. I'm going to anticipate that perhaps there might be some medical imaging on the road or down the road. So I'm going to go ahead and I'm also going to add in a urine qualitative beta just by placing a check mark. So I have 11 orders that I want to submit. So I'm going to go ahead and hit submit and they're going to save. Just kind of seeing these messages in the corner of my screen. Okay, so triage essentially for me is done. To get back to the last tracker I was on, I'm going to hit this X in the top corner. You can see that my patient now has fallen off that to be triage tracker because I've completed that action. We put that patient in the exams area of my department. So if I were to hit that exams tracker, I do see my patient in exam room 7. So now let's pretend that I am the primary nurse, realizing that very small sites, you might have one nurse that does it all. But if there was a change, first thing that I would do as the primary nurse is I would come and sign up for my patient. So I would go into the staff column and hit that sign up button and hit sign up. Automatically, it's going to attach my name as that primary nurse. I'm going to review my tracker. So I can see I've got some sort of orders on this patient and I have some sort of specimen to collect. If I click into this orders field, I get an acknowledge orders pop-up. It's going to list all the orders that are most recent that I have not yet acknowledged. I can check them off one at a time and hit save, or I can review them as a whole and hit select all at the top and then click save. Once I acknowledge these orders, that order flag is removed. It doesn't mean I've acted on these orders. That acknowledgement is almost like a read receipt in the background. It timestamps that I've seen these orders. If somebody else had acknowledged these for me, but I had not yet seen them, I would have the word new in this column alerting me that there's new orders that I haven't seen that maybe had some acknowledgement elsewhere. Okay, so I'm going to want to now start documenting on my patient. So I've got my patient highlighted on my tracker. The background's now green. I'm going to hit this pen icon on top in this document routine. This is going to launch me immediately into my nursing work list. And the work list is just comprised of suggested assessments and interventions. The work list is going to load by chief complaint. Some assessments like vital signs or pain will apply to every single CEDAS complaint. My patient came in with flank pain, so I have a suggested GU assessment. If this patient came in with chest pain, I would have a cardiorespiratory assessment. I'm going to go ahead and collect these urine samples. So you can see that I've got both here. Let's say my patient voided. I'm going to place 2 check marks here. I'm going to hit document. I could document my urine source. Hitting save and exit is going to mark them as collected. I would send them off to the lab. My status is now complete, and if I were to refresh my work list, they now drop off. Other thing I'm going to document, I'm just trying to be really mindful for time. So I'm not going to get into all the documentation I would do as a nurse. Let's pretend I've done a pain assessment, a GU assessment, and vital signs, but I will document this saline log. So I have a standalone flag order here, and I have my IV assessment order. So I'm going to place 2 check marks here, and I'm going to hit document on the header. I need to pick my IV location. So I say I placed an IV in the right form. Okay, so I inserted my IV, and we're going to say I did this today and now. It's peripheral. I was a good emerge nurse, and I put in an 18 on the first attempt. I'm going to hit save and exit to complete. It'll now file a last done time. I definitely, if I don't agree with some of these assessments, I can remove them off my work list. And likewise, if there are missing assessments, maybe I wanted to do a respiratory assessment, I could hit add and add any intervention from the catalog. So I'm done my nursing charting. The last thing I would have to do right now as this primary nurse is remember that Toradol that I had ordered. So I want to go ahead and give that. My patient is complaining of pain. So if I hit this little drop down arrow beside the document button, I can launch directly into my medication administration record. I need to put in my unique 4-digit PIN number to access the MAR. I have 1 medication for this patient. I can see the Toradol 10 milligrams IVIM. If I'm grabbing the 30 milligram per mil vial, it's going to tell me I'm giving 0.33 mils to this patient. In real life, I would have a barcode scanner, and I would scan the barcode on my patient's armband to verify that I, in fact, have the right patient. I'm going to have to just manually override this for the sake of the demo, but I normally would scan this. I'm going to put in the patient's account number. And you can see at the top, it now tells me I verified my patient. The next thing I would do in real life is I would take that barcode scanner, and I'm actually going to scan my Toradol bottle, and it's going to, the active scanning will sign off this medication. But again, I'm going to have to manually override this for the sake of the demo. So I'm going to say I gave this IV direct push. I go to the administration column. It's going to tell me that 10 milligrams is ordered. That's what I gave. I'm going to go ahead and say, okay, and save. To get back to my tracker, I just need to hit this close at the top. Now you can see in my detail box, I'm alerted that 30 minutes from now, I should go back and reassess my patient's pain level. Before I turn this over to Sherry, I'm going to just really quickly talk about registration. My patient is in a pre-ER status. At some point, we have to register these patients. We will not be permitted to discharge this patient until registration is complete. And obviously, we do want to register our patients in a timely fashion. Who does this work varies across one-hit sites. Larger sites tend to have clerical support 24/7, so it's the clerks that do it. Small sites, this lands on nursing, and kind of those mid-range hospitals might have clerical support during the day and nursing after hours. So to register this patient in the EDM module, I highlight my patient and I come up to this white square button here and I select registration. Basically, if this is a new patient, I'm going to fill out all required fields because this patient was searched and selected from the MPI fields. I'm going to go through all these tabs and just verify that the information is still correct. I do have to address this insurance tab, and I will have to verify this health card this visit. So I'm going to go ahead and I'm going to register this patient in the background. I'm going to stop sharing my screen and turn it over to Sherry. We will spend a little more time talking about registration in tomorrow's demo when we do inpatient or ED to inpatient. So Sherry, it's yours.
Thanks, Erin. I'm going to steal the share. So this demo, I'm going to be the physician. So I'm going to play the role of the duty doctor in Emerge in North Bay, where Erin was just triaging her patient. Very similar to the nursing trackers, the physician's trackers also have tabs. Because I'm regional, you'll see I do have an SA, so Surrey Hospital list, and a My list for North Bay. And there is a list of more trackers over here, which I can scroll through and find trackers for my areas, the to be seen, the waiting room, certain areas like the acute care area or the observation areas, and I can go through those lists of trackers through my shift as I want to find my patients. For now, and for the purpose of the demo, most of our physicians will stay on their My list and on the to be seen tracker, looking for patients that they need to pick up. Very similar to the nursing screen, you can see across the top black navigation bar, I have many icons to use. So I can open a chart if I highlight a patient and document orders all within that patient's chart. I have access in and out of the tracker to the acute status board, to the ambulatory clinic home board, which you saw yesterday. So the physicians have access to toggle back and forth amongst their workflows, depending on whether they have one role, ED physician, or they do a multitude of roles. So for this demo, I'm going to go to the to be seen tracker, where I'm going to pick up Erin's patient. So Erin patient Zap, you can see that the physician's screen is very similar to the nursing screen. A few differences. The physicians have an order section, which will give me what orders have been placed on my patient prior to me even picking them up. So you can see there's labs, and I'll talk about these in a minute, and there's something for the MAR and the saline lock that she implemented, as well as the urine and urinalysis. On the same sense that Erin said, I have a location for my patient. I have the CTAS score on my patient, how long they've been in the department, their age, what their chief complaint is. The triage note, I can click on the little pink icon and it will show me what the nurse has triaged. So this is a preview of what Erin has put into her documentation, so I can get a sense of what this patient is all about. Very similar to the nursing staff, the physicians also have a drop down where they've asked for limited things on this particular tracker for the details box, but each tracker does have a details box, which does include more elements of the chart if you wanted to see them. I get the vital signs in this gray banner at the top, where I can see the most recent set of vitals that are done on this patient. Similarly to Erin, I have a sign up button. So if I'm going to pick up this patient and I'm going to go attend to this patient, I would sign up for my patient, and then it will show up on my My list. So it disappears from the to be seen and is now in the physician's own list. So you can see now my document's a little bit bigger. The patient's now in an MD assess. The home meds have not been charted. I can still see the orders. I easily have an order button in the middle. If I wanted to place orders quickly, I can just click that. The details box here, I'll drop down. Again, as I said, has far more details than the to be tracker does. So these get a little deeper with detail as your physician's workflows extend. So acute care has far more entities as well. So I have my patient and I've signed up. I'm going to go see my patient. On my list, as I said, you can see the triage note. So I already have some details. I'm going to go get some history for my patient. I could also launch the chart from here. So if I'm highlighted on my patient and I click the chart, this will open into the full chart, which you saw yesterday if you attended the EHR. From here, I get a lot more details on my patient. Any value. So luckily enough, we have a lab friend who's being our co-conspirator today. And so she's already given me some results on the blood work that Erin put in. In the widget, I can see Erin's already done the MAR, she's already done the IV, the height and weight's done, infection control's done. And so I have lots of details that I can gather from the chart here and easily jump into any of these entities for my patient. I can also get to the activity where I can see past visits. We did this with the HR yesterday, so I can see this patient's been in a few times for flank pain. And it's not inconsistent with this patient's history, knowing that she has a history of renal colic. So I'm going to place some more orders. I know that Erin did some labs. I can see the urinalysis come back. You can see I can also get my results here. So if I click open my results panel, I can actually see what the lab had to say and then make some decisions from there. I've seen my patient. I'm going to up some of the clinical investigations we're going to do on my patient. So like Erin, the physicians also have an order set that they could use that isn't a medical directive, but it's an enhancement of all the orders that were in the flank pain ED directive. Not copies, but an enhancement. I have some favorites. You can see my physician user. I have a CBC that I always keep on my favorites. I have a general admit set that I keep on my favorites. And I was playing around with the frequencies of glucose the other day, so you can see those as well. But if I put in ED flank pain, or I could just put in flank pain, because our doctors like to use shortcuts, it will pull up the order sets associated to the wording. So it is a keyword search, not necessarily what it starts with. As I drop down the order set, it does collapse into sections. You can see we have labels, which collapse upwardly, so I don't have to necessarily look at all of the items that I don't want to give my patient. I know she has a saline lock-in. I think maybe I'll give them, they look a little dehydrated. Let's give them a small bolus. Erin did give some Toradol, and I can see here this Toradol 10 milligrams ordered max 1 dose. I can see that that was ordered and that Erin has already taken care of that. So I wouldn't necessarily click that again, but it's good for me to know. And then if I wanted to give more doses, say Q4, I could change my frequency. So if I go, I don't anticipate my patient staying that long, but let's say it's a long wait in Emerge today, I can choose it, and then I can change it to a Q4, and I can change it to a PRN, just in case my patient stays. I'm going to pick pain, moderate, safe. I want to give my patient a little bit more medication, so I'm going to give them a little higher dose right now. Again, I can change this to whatever I'd like. I'm going to give it once. I want to start it now. I want 1 dose, and that's all I want to give. You can see how these strings have modifications. So your physician could pick a medication and then modify the dosing as they choose. I know the patient's had lab work done, so I'm going to skip that, and I'm going to go straight to my diagnostics, and I'm going to put in for a CT of the abdomen and pelvis. We have some mandatory questions that appear on the screen. I'll drop down the full screen so you can see it. Relevant history, I'm going to say flank pain. And our physicians can dictate. Most of the Northeast sites have Dragon and Nuance to dictate, and you can dictate in any field within Meditech. So our physicians can dictate into these spaces. If they chose more than 1 CT, this relevant history would actually copy, so they don't have to repeat it 3 or 4 times. Most importantly, on a triage, a trauma patient, that would be where we'd want to make sure that the physicians can have that easeability where it'll default in if they do multiple of the same diagnostic imaging test. I'm going to put history of renal colic. Sorry for my slow typing. Then some mandatory questions: is the patient on dialysis? No, they are not. And does my patient have any signs or symptoms or suspect of an acute kidney injury? And for now, I'm going to say no, the EGFR was fine. Just like Erin, I have a submit, and I submit my orders. Now, I did get a red flag. I got a red flag for a conflict. So medications have interactions on them. And so this particular interaction is telling me that I have a codeine allergy. I'm willing to risk this today because my patient has constipation, 1 dose, I can override. Now, some medications do come with a conflict that you can't override depending on what the actual interaction is. But I'm going to override this one. And I have to put in my 4-digit PIN just like Erin did. So now I can see the current list of orders for my patient come up. I can see everything that is here, what's been ordered. If I wanted to see the historical, so what has been done on the patient, I'd hit historical, and then I could see all of the other orders that Erin had placed earlier. So all of her labs and her Toradol. I've seen my patient, I've enhanced the orders. Now I'm going to document on my patient. So I'm going to go to document. I could see the list of all documents open for PDoc if I wanted to show all, and it doesn't, there we go. I have favorited the ED note because that would be my preference if I'm working as a physician in Emerge most of the time. So the My list, if I go back and click over to My, and then unclick the Show All, I will see any that I've favorited as a physician. So your physicians can easily get to their PDocs, and that's what we call them, physician documentation, and have their ready-made templates when they're working. So if they only ever do consultations, you'll see that here. I'm an ED physician today, so I'm going to open that PDoc template. I've chosen the ED adult template with the asterisks. That particular template comes with all of the extra sections for the exam and the vitals and the medications and allergies and the family medical history, the handover note, and all of these things. There is another template which only has the bare bones, which would be your HPI and narrative in the discharge plan. The sites have the choice of either or. Some physicians like this method with the easeability of these sections where I can pick things and I can get drop downs, or I can hit the rapid and get a drop down list. Some of our physicians dislike this, so they only ever use the narrative section. It's entirely physician preference. We do have all documents available to all sites currently, so they have a choice to use whichever one they like. Within the template, you can see that the triage note from Erin's documentation earlier, as well as the vital signs, are all displayed. The time that I picked up the patient to see the patient is also tracked within this document, so you can see that as well. Then I would dictate, or I can type. I can also choose to use some canned text if I've created some quick text if I've created some as a physician. Or I can input formatted data from the chart into my note as well. I'm going to cheat just to save time. I'm just going to put testing. So you can see any section of this. If I wanted to continue, I could toggle through some of these drop downs as well. We do have special sections for our physicians. So a medical decision section where we have some of the scoring rules built out so that our physicians can easily get things like the TIMI score or our stroke scores, those kind of things, a little easier into the chart, knowing that our physicians tend to use MedCalc to do it on online version, but we want to get that into the chart as well. So we've created those here so our physicians can utilize them and have them documented easily. So I've seen my patient, they're going to CT. I'm going to save my note for now, and it will save in a draft status on my chart. And I can see I have a note pending. And it will come up with draft once it's filed. I can see that my urines come back and my lab works come back, and you can click into those easily enough to see the results. And as these come back, they will highlight green. The single dot is showing an abnormal. Of course, critical would come back as red, but the green highlight means that there's a result there. So if I go into the HCG, even though it doesn't have a button, I see it's negative. It would come back with an abnormal if it was positive. Erin, did you want to pick up the patient again and then I'll do the discharge, or did you want me to go straight to discharge?
No, I'll pick up the patient.
Okay, so I'll stop sharing.
Okay, so while Sherry was putting in those orders, I went ahead and I signed off that IV. So same thing, I launch into my MAR. I would have scanned the patient's armband, scan the barcode on my IV. But I just wanted to show you what it looks like when you have an infusion running on your detail box. So you get a gas gauge. So right now it's showing me that it's full. As this bolus starts ticking down, that gas gauge is going to empty, and it'll actually alert me when my bag is empty. So I can see that Sherry's put in orders. Same thing, I would acknowledge them just like I showed you earlier. Let's say this patient went to CAT scan and back. This is when I would use the status events. So where I could say patient went to CT. And then when my patient comes back, I would go ahead and say they're back in room. If everything's back, I've given my pain medication, the bolus is complete. And now I want that physician to come back and reassess that patient. I would switch this status event to MD reassess. And then this is the point where Sherry would come back and do her discharge piece. We'll stop sharing, share.
Perfect. Okay. So the imaging, to be honest, just so everybody's aware, we don't have an imaging person on with us today to give us a report back, but that would also highlight very similarly. You see the green one up here on Granny Smith. So a green highlight, and if there was something abnormal, it would have a priority button like the labs do. So if I go back to my patient and I want to discharge my patient, so I'm going to go back into my document, my ED document that I had as a draft. All of the PDocs to do with eMERGE have the discharge plan embedded within them. So I do have a discharge button up here, which I could launch into the discharge plan. Most physicians want to write their note specifying that the patient is going home. I can access the active problem. So if I wanted to say that my patient is resolved from it, I can also put the discharge problem. So my HIM department will see this discharge problem resulting from the active problem list. I can give instructions to my nurse as well. My patient has run fevers, so I would like it if please give the patient instructions for fever management. Most of our facilities currently in the ED departments are writing their prescriptions. Not many of them are using the prescriptions function out of the discharge plan. I will show that tomorrow with the patients that are being discharged from the facility. Using the prescription out of the discharge plan does revolve around having a best possible medication history done on your patient and linked to the visit meds. That's why our physicians in the emergency room don't tend to use this. The disposition as well as the date and time are grayed out for me as a physician because the nurses are the ones who control when the patient actually leaves, not physicians. So I'm satisfied with my note. I'm satisfied with what I've given my patient. I'm going to tick this ready for discharge at the top. This notifies Erin that my patient can go. And then I would sign my note, which would make this signed within the chart as a final. My patient will fall off of my list. Erin can speak to the departed process and how these fall off of trackers. There you go, Erin.
Okay, so let me just refresh my tracker. So Sherry had updated that ED status ready for discharge. I just want to pull up another menu here. So if you were to scroll through this menu, you'll notice that ready for discharge does not exist here. So we know that that originates from the physician, and we treat that like the discharge order in emerge. So I can see that physician says this patient's ready to go. So as a nurse, I would want to clean up any last minute documentation that I might have. So I did put in that IV. So I'm going to definitely want to remove that IV and document that I did that. So I would come back in here. This time I'm going to say I removed it, and site looks fine, and hit save and exit. I might do any last minute documentation, document that I gave belongings back to the patient, perhaps a repeat set of vital signs. Once I'm done with this, I'm going to go up into the discharge plan. So first thing I'm going to do is I see that physician has requested I give discharge instructions for fever management. So we do have a catalog of pre-made discharge instructions in the ED. So if I click into here, I can search. So I know I want the fever sheet. So if I hit fever, I'm going to pick fever adult and click OK. I'll just show you what that looks like. I can hit this little paper icon to preview it. I'll try to make it a lot bigger so you guys can see. So pretty standard, what's a fever, how to check your temperature, you know, those typical discharge instructions. Next thing that I have to do, it's in red, is I need to do a discharge assessment. I need to do this on every single patient. I could have done this from my work list, or I can do it here. It's the same assessment. So I'm going to go ahead and hit this pencil icon to the side, and I'm going to just fill in as much as I know. So I know this patient's going home. I'm the one sending them home. Maybe their family members going with them in their ambulatory. I know I gave a fever sheet. If there was any upcoming appointments or belongings, I could also record it here. I'm going to hit save and exit. That red field now goes away. So I've met one of those discharge requirements. The next thing I need to do is enter a patient disposition. So if I click into this field, I get those NACRS disposition codes that we do for emerge. So I'm going to go ahead and send this patient home and pick that. And then when I've satisfied all discharge components, I will have access to apply a discharge date and time. So I'm going to go ahead and say today and now. It's going to just remind me that, are you sure you want to do this? Yep. And I'm going to hit save and close. Now, my patient is going to fall off all trackers in the merge, with the exception of if I'd added them to my list, they'll stay there for a little bit, but all other trackers like my all patients or my exams, they're going to fall off, and they will populate my discharge tracker. So I'd see my patient here. And which one was it? It was this one. We've played with this patient a lot today. I know there was a question, what does EC test look like? When I can see that Ernie question online, so that too real quick. So what does EC test look like? So if I were to open up the patient's chart, it'll file under Nurse Allied Health, under Nursing. Oh, is this the right one? Maybe this is not the patient from today. Which is it? 38 minutes. No, it's got to be this one. It will be in here. And this is what it looks like. So it has, if I had done like EMS notes, objective notes, they would all file separately. Only what I've recorded gets saved into the EHR. There was another question about Ernie data. So it is recorded in the background. Easiest spot to look at it, we have something called ED visit data in the emergency department. And it's on this first screen. So we were kind of rushing through this. So a lot of things are automatically filled out. So like arrival date. So once I receive that patient, that gets timestamped. Once Sherry signed up for the patient, I get a PIA time. My triage time occurs once that EC test files into Meditech. There are some things that require a manual entry. So your EMS transfer times. The system can't differentiate at what point this patient now, TOA occurred with EMS and we accepted care. So that is something that is a manual requirement. Currently right now there are MPIA tends to be manual, and Meditech is actively working on this. Consult data is another thing that's manual. So if I had consulted cardiology, I'm just going to go to a live patient because this patient's discharged. So say this patient, I did critical, maybe plastics at my facility. I could come here, I write down the date or time I've criticaled out, or if I've called in my facility, depending on the size. And I can search for plastics and save. And then now when plastics either arrives or they call back, I can enter in the arrival date and time. I can either plunk it in or hit down. Okay, I'm going to stop sharing for a second so I can actually see the chat. Okay, so I'm just going to go back to a couple of questions. Discharge, Stacy Brown, does discharge, is it nursing or clerks? That is site dependent. So we have some sites where it's clerical staff that only do discharge. Some of our smaller sites, it is nursing. What else have I missed? CDU will be a manual entry, but we do have some, like Julie said, sort of, we do have some timestamps to help assist with this process. Can Meditech receive reception screen completed in EC tasks? No, so we do infection control only in Meditech. Some of those other EC task features where you can enter in home meds, treatment options, they don't file nicely into where we want them in Meditech. So nurses would have to re-enter them. Like if you put home medications into that field in EC tasks, it's not going to update the BPMH. So then nurses are having to double document. So some of these fields, we tell staff just to ignore them in EC tasks because you're going to put them in Meditech, and infection control is one of them. If I were to start that patient in EC tasks, it will not create the patient in Meditech. The patient has to start in Meditech first, and Meditech's the one that generates the account. Other questions?
Erin, did you want to talk about the Ernie data at all?
Yeah, I touched on that.
Oh, perfect. Okay.
Yeah.
That was the only other thing I was missing.
There's one about the ED time if it's put in later. I'm just trying to find it here. What happens to discharge date and time if nursing can't do this in real time? Wouldn't this mess up with the wait times?
You can backdate it. You can backdate it. So there is a field on the discharge assessment too. So if I know I sent my patient home at 1 o'clock, no, it's a total gong show in my department, and I don't get to this until 3:30 or 1:30. I can backdate that discharge date and time. There is wiggle room that way, and particularly those the larger sites like HSN, North Bay, Sioux area, they have clerical staff completing discharge. So nursing will do what we call as a departure, so a soft discharge. The patient is, we signal that the patient has left physically, but we leave that account open. Clerical staff cleans up ERNI data, make sure everything's filled out, and then they're going to backdate that discharge date and time to the time that the nurse has indicated the patient left physically. So again, that's site dependent on which workflow you prefer.
There's a question about what does a referral look like for something like PEDS outpatient ER follow-up?
Patient, that's a lot of site dependencies. Sherry, how do we want to show that?
Well, it depends if it's an outpatient clinic, right? So if
Yeah.
that's a clinic that's running, it would be set up differently than if it's, I'll use our nurse practitioner in North Bay as an example, right? Like patients come back to her and register through ED. It just depends on the site, on how it's treated. If it's an outpatient program, then it's a clinic. And and then would have a schedule like anything else? Or is it more like a call back situation where the patient's told to come back?
Yeah, an example would be, so they were able to be discharged from Emerge today, but Emerge is referring them to our outpatient clinic in-house to have a follow-up assessment the next day or a day later by the pediatrician on call. And right now it would be a relatively manual process where a Emerge referral form would get faxed. But I'm assuming that this would probably all happen somewhere in Expanse. And on that discharge screen you were going through, I could see a referral section. So I wasn't
So
sure.
the referral section in the discharge plan is for noting where the referrals are going. It doesn't actually function as in it flows anywhere. We do have a number of orders built as refer to outpatient clinic XYZ. I'll just that may auto print to a clinic, or we do have some that go into status board formats. It would depend on how that clinic is also going to be set up. Because would it be an ambulatory clinic, right? Would it use the AMP module versus the acute modules? That would make a difference as well.
Are there any other questions for the team? I've seen that they've been keeping the answers up to date in the chat.
Well, if there's no further questions, I did want to thank the team from One Hits today, and thank them for their time. All of those also from the team who are in the background answering questions on the chat for us. Just a reminder, there is another demo tomorrow, 9 to 10 a.m. Eastern time, and it will see a patient sort of right from coming in through the Emerge into admission, into an inpatient acute visit, right through discharge. So if you're interested in that, please join us again tomorrow. It's the same link that you used for the meeting today. And if you need an invitation to that or anything, please just reach out to either myself or your change specialist, and we'd be happy to give you that. We will have the demos, again, we have recorded them, so they will be available either right now by sort of asking us, we'll send a link, or eventually we are planning to have them available for all staff across the region in a sort of centrally available place. We're just working on where that's going to be at the moment. So yes, thank you very much to One Hits, much appreciated, and we'll see everyone again tomorrow. Take care.